when we're talking about cancer prevention and looking at what are the things that we can do to make our lives a little bit better and to help maintain our quality of life, because ultimately, we can do a lot of different things to people as providers. But the question is, what should we be doing for you, and what are the things that you want to have done, so that we have these having the appointments to have these kinds of conversations with your provider, your mid-level practitioner, your physician, to kind of decide what is the best practice, but what is practical for you is important. And separate from whatever discussion we would have about preventive screenings, cancer screenings particularly, there's other things that we always have to keep in mind, and that is risk reduction. Because we know that for many of the cancers out there, for many of the illnesses and those things that cause the most costs in healthcare are related to smoking and obesity. So if you smoke, please stop. If you need help stopping, let us know, and we would be happy to work with you on it. Likewise, if we have issues of overweight and obesity, weight management can be important. As we get older, however, being as tight about weight management may not have as much of the effect as we need, but particularly for your children, your grandchildren, thinking about obesity, childhood obesity, because of the risk factors for diabetes and arthritis and any number of other conditions, is important to have that kind of conversation. So eating healthy, exercising regularly, visiting your provider, and getting some of these screenings are going to be important as well. When we talk about cancer screenings particularly, the questions come up of who are we going to screen, what are we going to screen for, when do we start the screening, how are we going to do the screening, what tests are we going to use, and when do we stop doing this? And so some of the things we need to think about are, what is the lifetime risk of one person for a disease process? We know that when we're looking at general recommendations, we're kind of taking an epidemiologic approach, a chances are odds sort of approach of, in general, we see this much incidence, these kinds of things. And so because the risk is high enough, we want to go ahead and look for the disease process. The benefits to the screening is, really based on when we get it and lead time. Because I think that when we look at some of the slides later on, we're going to see that we've had a lot of improvement in terms of some of our cancers and finding them early, being able to treat them, and leading to potentially cure, which is defined as a 5-year survival rate. And I think part of the reason that we've had such success is because we've seen earlier screening, so that we have we can do something during that lead time before the problem, a small problem becomes a large problem, like an invasive cancer. But there's also a risk of harms to screening. And I think a potential example of that would be prostate cancer, where, yes, we have a simple test that we can screen for elevations of an antigen in the blood system. But we also know that prostate cancer, while it's very common, isn't usually what does a person in. And so we may end up screening for disease, finding a potential problem that may not actually change, your life course, but may also then result in doing additional testing and more invasive things. I think that, we have examples of mammography, where if we start doing the screenings too early, we may find abnormal tissue that leads to then more testing and more anxiety and more cost. And so you want to kind of balance what are the risks and what are the benefits for the testing, and try and figure out for the individual person what's going to be the best option. And then, of course, patient preference. This, the fact that you're here today suggests that this is an important conversation to have with your provider about, this is what is important to me, this is what I want to have done, this is what I don't want to have done. And so we base the general recommendations to individualized opportunities to use this as a springboard then to talk about other things. So the other consideration is, this person-specific sort of things. What is their functional status? What is their living situation? What is the social support system? Particularly as we talk about health screenings as we get older. We know that cancer tends to increase as we get older. We know that we have tests available to us, but that doesn't necessarily mean that we continue these tests for a long period of time. Am I in a spot that's getting echo? Okay. Just is the way it is. Okay. And certainly the costs of these tests need to be considered. One of the nice things with the ACA, the Affordable Care Act, whether or not you like it or dislike it, is that, is the coverage for U.S. Preventive Service Task Force recommendations that have a level A or a level B. And we'll talk about what that means later on. But for our Medicare population, if it's a recommended test that has a level A or level B recommendation, then it is covered with no cost, no additional copay to the patient. And so we've seen some great strides in getting some of our mammography, getting our colonoscopy, and some of our other testing done because Medicare automatically pays for it. And as of 2014, that generalization for A and B recommendations has been extended to all of the insurance programs because of the Affordable Care Act. And then the other consideration is quality of life, as we talked about, and life expectancy. Because if there is a lag time between the time that you develop abnormal changes on your skin of the cervix, the skin in the breast, the skin in the colon, or your skin, between the time that you have these changes to the time you have an actual tumor, to the time you have spread of the tumor or invasiveness, to the time that one would die, there may be very long periods of time between the time of diagnosis and death. And so kind of taking that window of opportunity to look at when we do these screenings is going to have an important role. If there's any questions, you please let me know. We can always stop and continue the conversation. This is sort of a slide that I was, starting to allude to. We know that over the course of a lifetime, we live, we die. And so the point of prevention and screening is primary, secondary, and tertiary, meaning that primary screening is where we do it to the general population because it's a good thing to do, and we aren't expecting to find it necessarily. It becomes a secondary preventive or a screening thing when you have risk factors, okay? So you have a higher need to look for this test. But in both of these states, you don't already have the diagnosis of disease. So this is case finding or surveillance, where we don't think you have it, but you either should get the test done or you're at risk for getting it. So we're looking for the disease state. And then tertiary prevention are those things that we can do after we've made the diagnosis to kind of keep you healthy or to try and prolong and improve quality of life. Okay? So screening tests are designed to look for disease in the average population who is at normal to low risk and don't have symptoms. Okay? And we call that primary prevention, and our goal is early detection and reducing the morbidity or death or illness as well as mortality. Okay? We're not doing the test to diagnose a condition because we don't know if you have it. And the prevalence, or how much of it do we see in the population, is defined, for each of the different conditions. Case finding is in patients who are at risk. So if you have risk factors for something, we're still doing screening, but it's called case finding. Okay? And it may be for patients who are at higher risk because they have symptoms, that they have familial risks or exposures, that they've had And we kind of think of it as secondary prevention because once we find it, we make the diagnosis and we can start doing things about it. And then, again, the goal is decreasing morbidity and managing disease and making the diagnosis. Okay? All right. Well, yeah, go ahead.
Is it too soon to ask about your participation in the decision after you have found something or we have discovered something?
Mm-hmm. No, it's not, I mean...
Would it help us decide?
Mm-hmm. I think, you know, what you're bringing, the question is whether, you know, when to have the conversation with the doctor or your provider about when you find something, what are we going to do about it? And I think that that's an important question to actually start at the beginning of the conversation. Because there's both, we can look for something, but then the question is, what do you want to do if we find something? And so that's a critical piece, particularly as we get older. That, you know, so what if you find something, I've got these other things going on, I don't want to get surgery or I don't want to do something about it, in which case then why do we do the test? And we probably don't need to do the test. And so yeah, having that conversation, and again, at multiple points in the process, but you know, we always talk about asking the last question first. And that last question is, if we find something, do you want us to do anything about it? Okay? And, you know, I think when we have those conversations about at end-of-life care, you know, do you want CPR? Do you want to be on a ventilator? Do you want, you know, dialysis? Do you want whatever? You know, we always think about, you know, well, what's the ultimate outcome from that? And to a certain degree, the same thing applies to these screening tests. That, yeah, you know, as I said at the beginning of our talk, there's a lot of things we can do to you, but what are the things that we want to do for you? And that's going to be from your feedback of this is what is important to me, and this is what I value, and this is what I want to pursue. So, and you know, to complicate the matter further is there's lots of different recommendations out there. So I'm going to be kind of basing on the U.S. Preventive Services Task Force, which is a national body that is convened to kind of look at the best evidence out there and make a generalized recommendation. But some of the slides that you're going to see are data from the American Cancer Society. So you know, their vested interest is look for cancer. So they may have more stringent or more aggressive recommendations than maybe the U.S. Preventive Services Task Force has based on the evidence. And then, you know, primary care societies also have their recommendations. And then subspecialty societies, you know, OBGYN as a specialty may have a different set of recommendations for cancer screening in women because that's what they're all about. Urologists may have a different sort of recommendations because that's what they deal with all the time. GI doctors may have a different set of recommendations. And so you can find lots of different recommendations out there of what tests to do, how often, when to start, when to stop. But we kind of have to be a little rational about it and figure out, well, what's the best in general recommendation going to be? And then if you have other risk factors or other reasons to do earlier screening or different screening from the recommendations, then we would, you know, implement those. Okay? So if you went to this website of the U.S. Preventive Services Task Force, you could pull up any number of conditions and say, what are the best evidence-based recommendations that we have out there? And, you know, they're along all of these different categories, and it'd be interesting to talk about some of these at other talks. So if we want to talk about osteoporosis, or we want to talk about exercise and nutritional sorts of things, you know, or immunizations, because we're going to kind of just touch on some of that today. But, you know, there's a whole bunch of things out there that you can look at. And, you know, docs have like a nice little cheat sheet program on their handheld devices that can put in your age, your sex, your smoking risk, and kind of pull up what the most common recommendations are based on the Preventive Services Task Force. And so, you know, there's a lot of help out there and a lot of things to do. Okay. So, you know, separate from the screenings, These are the things that should get done at least once a year when you go to your doctor's office, okay? Obviously, they're going to take vital signs, but we need to screen for blood pressure on an annual basis. And then if you're on blood pressure medicines, maybe making sure that you're not having dizziness or lightheadedness or low blood pressure related to your medicines. Looking for our changes in weight and changes in height, particularly as a thing for osteoporosis. And so, sometimes we're surprised by what your height was at age 50 versus what your height is at age 65 or 70. And loss of bone height is a marker for, it helps to make the diagnosis of osteoporosis and is an important screening sort of a thing, as well as it's used to calculate BMI or body mass index, which is a reflection of weight and obesity. For our older populations, these are some of the additional things we want to think about. Issues of safety, whether, throughout the entire age spectrum, but issues of abuse, issues of pain, issues of activities of daily living or instrumental activities of daily living. What am I able to do? What am I not able to do? Obviously, a medication review, and then making recommendations of lifestyle and anticipatory guidance. Okay, so when the U.S. Preventive Services Task Force makes its recommendations, they give it a letter grade of A, B, C, D, or I. And like I said, in 2014, if it's an A or B recommendation, those are supposed to be offered to patients at no additional cost to you other than what the insurance would pay for the test. And insurance companies should not be putting additional hurdles into restricting these tests if they have the A and B recommendation and it's within the guidelines. So you could argue that, a colonoscopy may be an A or B recommendation, but not an annual colonoscopy. PSA may not be an annual sort of a test, but they are covered, if it's an A and B recommendation within the time frame of the recommended services. Okay? So, yes?
How about a bone density test? Are those at our age should be done, or we have to tell the doctor when to do this?
Yeah. So the issue of bone mineral density testing and when those should be done is a great separate talk, but the short answer is we should screen for osteoporosis at age 65, potentially do a bone mineral density testing at periodic intervals, like every 5 years if we have it there. And then if you are chronically on steroids, if you have had some small minor fractures, you may, and if there's a way of calculating based on your age, sex, weight, height, a number of variables. If your fracture risk is higher, then you might do bone mineral density testing sooner than age 65. But typically it's covered as a Medicare service at 65. Okay? So a letter A recommendation, A is like, there's no question, it's a good recommendation. The evidence supports getting it done. Level B is the evidence is reasonable. It may not have the most rigorous testing, like a randomized controlled trial that says this is absolutely what should be done, but it's pretty darn good evidence, and that the outcomes and risks are outweighed, or the benefits are outweighed by the risks and harms. Level C is, we don't know what to say. So they won't say yes or no. And so a level C recommendation is one we probably would still talk about with you as a patient, and kind of, if we agreed that this is an important test, we would do it and, go from there. A recommendation of D is probably we shouldn't be doing it, okay? And then a recommendation of I is the most frustrating one, because the U.S. Preventive Task Force would say, well, we don't have enough evidence to say yes or no, so leave it up to you, or leave it up to you and your provider to talk about. Okay? All right. So the next couple of slides kind of look at why cancer screening is important and what impact cancer screenings may have. This is just a representation that in 2013, there were about 300,000 deaths in men, 273,000 deaths in women from cancers. And the distribution of the cancers are here. In men, the highest ones were lung, prostate, colorectal, and then pancreas, and a number of other things. In women, lung, breast, colon, and then pancreas as well. So we're going to kind of like draw the line here and really kind of focus on the top three cancer deaths in men and women. Interestingly, following studies from 1930 to 2010, the incidence of, or the death rates, we have seen various changes. For some diseases like blood cancer, leukemia, liver cancer, pancreatic cancer, any of these, they've really kind of stayed about the same. We haven't been able to do any kind of cancer screening initiative to make a difference in those. In prostate, we've seen a steady fall. Colorectal, we've been able to see a fall. And lung cancer, we've been able to see a fall. In women, it's been a delayed fall. But and whether or not cancer screening's made a difference, obviously for lung and bronchus cancers, smoking cessation has made the biggest difference in making that fall. But in colorectal and prostate screening, and we'll see on the next slide for breast, cancer screenings can make a difference for them. In women, a slight fall in breast cancer, steady fall in colorectal, and we're just now starting to see the fall in lung cancer. For whatever reason, the messaging out there of smoking cessation has an epidemiologic delay in women than men because we've been really harping men to stop smoking sooner than we were harping women to stop smoking. Right or wrong? And this is an interesting slide. And the reason it's interesting is that this blue line represents the curve of where we're at for men and for women in all of our cancer deaths. And this is if you followed a natural progression of what we would have expected to see. So the American Cancer Society and health professionals would like to suggest that the difference between what we would have thought and what we're actually seeing are lives saved. And that's on the order of 833,000 lives saved between 91 and 2009. 344,000 women cancer deaths were saved or averted over that same period of time. So, we'd like to believe that we've saved or averted cancer death in over 1 million people over this period of time because of doing these cancer screenings and looking and surveillance sort of things. So how do you put a price on that? Of the costs of all the tests versus the death versus the surgical costs and all the other healthcare related costs to things. But needless to say, for every every cancer that we can avert is going to have a net benefit cost. That being said, prostate may not be, but there's still a lot of other cancers that we haven't been able to make as much of an impact on. Okay. So we're expecting, and 2014 data is about the same, 800,000 new cancer cases each year in men and women. The data, did anybody watch TV yesterday? I was on Color 8 talking about some of the same stuff yesterday. And for Montana, the American Cancer Society estimates that there will be 5,800 new cases of cancer diagnosed in Montanans in 2014, and that there will probably be about 2,000 cancer-related deaths in the state of Montana in 2014. So, for whatever piece of the national data that is. Okay, so again, now we start talking about lifetime probability and risk. and I'm going too slow. We're not going to get all this stuff covered in the time we have, but we'll plow through it. So we know that based on the location of cancer in general for men, these are your risk probability of getting a cancer, 1 in 2, and then prostate, 1 in 6, lung, 1 in 13, and these are just for all comers. If you smoke, if you have other risk factors, those numbers change. But this is playing that probability, those odd sorts of things that, kind of is the basis for why we do the cancer screenings. And you can get this stuff from the American Cancer Society website as well. In women, probably 1 in 3 chance of a lifetime risk of getting cancers. 1 in 8 for breast, 1 in 16 for lung and bronchus, 1 in 21 for colon and rectum. So, and again, if you have additional risk factors, then you move yourself higher on that list, and then all the more reason to do some of our screenings. Okay? But this doesn't mean that you're going to die from these necessarily. Okay? Because if we can screen and we can find and we can intervene, then, we do a save, we do things great. But the chances of developing any of these could be important. Okay, this is just a slide to suggest that cure rates, defined as our 5-year survival rates, vary, but the ones that we can screen for, breast cancer, colon cancer, prostate cancer, and the most interesting one is uterine cancer, or not uterine, cervical. Cervical isn't even on here because we've done so well with that. If we find, because of surveillance and we're finding cancers earlier, we're more likely to be able to treat and get a suggested cure for the process. Again, if we can do it before you get the invasive cancers, then we're going to do better. And cervical cancer is an example of, because we're doing pap smear screening for cervical cancer, the total number of cases per year between 1960 and 2010 have gone down dramatically. And we've essentially had cures for cervical cancer. And now with the HPV vaccination for one of the viruses that cause the changes related to cervical cancers, we'll never be at a point where cervical cancer goes away, but we're at a point where not very many people are going to develop it. And American Cancer Society says that in the state of Montana, we would expect less than 50 new cases of cervical cancer in the state, hopefully, because we're getting so much screening. Okay, so breast cancer screening guidelines. This is one of those that you can see a lot of recommendations going across the board of when do we start, how often do we do it, when do we stop. U.S. Preventive Services Task Force recommends starting doing every other year cancer screening at age 50 to 74. So where the American College of Obstetrics and Gynecology, the American Cancer Society says start screening at age 40. And American Cancer Society would say get an annual mammogram. So now this is where we start, stirring up the pot, and depending on whose recommendations you want to follow, who's going to be right, who's going to be wrong. Well, but I think our best evidence is that starting mammogram screening, our current practice is to do a baseline mammogram between age 40 and 50, and then start I don't know what I'm doing. Okay, I won't move. And then do at least a mammogram every other year, or every 3 years after age 50. And then after age 75, maybe not pursuing mammograms. Okay? But if you're at higher risk, if you have a family history or anything like that, then you may want to do it earlier. this is where it becomes a problem. If we do mammograms in younger women who have, estrogenized breast tissue, they're going to have lumpier breasts. You're going to find more abnormalities, which may just be normal glandular tissue. That then leads us to have to put a needle or do additional testing to try and figure out what that is. And then it has just a little bit of abnormality enough to it that we have to do a lumpectomy and take out the thing to find out that it was or wasn't a cancer. More often it wasn't a cancer. So then we subjected this person to a lot of additional costs, a lot of additional worry, and additional testing that maybe, if we took a step back and didn't do all those sorts of things, might have made a difference. But if you had a sister that died of breast cancer and you're age 35, you are probably going to talk your doctor into getting a mammogram earlier rather than later. So, again, these are recommendations, these are guidelines, and this is our best practice, but the individual case is always going to be different. So other things that it talks about are self-breast exams. I used to really push and encourage people to do self-breast exam because you would notice changes before anybody else would. And while I still believe that to be the case, when we do it to scientific studies, it doesn't add to the testing or the cancer finding that the that the mammography does, or a clinical breast exam, something that we would do in the office would. Okay. So this is a B recommendation, and again would be then covered. All right. Okay. So in general, mammography has a sensitivity of finding an abnormality 56 to 95% of the time. And if you find it, it's specific for cancer, or if you don't find anything, it is specific to 94 to 97% of the time if you don't see something. That's how I think about sensitivity and specificity, okay? But that we'll find more abnormalities that may or may not be an issue in younger people with denser breasts and people on hormone replacement therapy. Okay. Trends in mammography use. We saw a general rise in the use of mammography up until about 2006, and it's sort of plateaued or even fallen. And so this is just a reminder that if the public awareness isn't out there, we need to keep the word up and keep going and keep screening for these sorts of things. And that the sad sort of thing is that if you are not insured, or if you don't have a source of primary health care, you are half as likely of getting any of these sorts of screenings. And so, just as important it is to doing these tests is having these visits with your doctor and having a doctor to go to or a mid-level provider to go to have these conversations about. And, and this is what the whole ACA thing is that if we had people on insurance and had people getting covered for their tests, you might be more likely to get it done. And we know that if, in breast cancer, a lot of people aren't, and that if once we do find it because they haven't been screened or tested, it's usually an invasive and, very bad disease as opposed to early disease. Okay. Cervical cancer, again, this is one of our success stories. But to summarize all the slides, basically the recommendations for Pap smear cervical cancer screening is in women at age 21 or 3 years after you've started having intercourse. So if you have daughters or granddaughters, we don't usually start Pap smear screening until age 21. But if they've been, sexually active at 16, then we would want to start screening, at 19 or something like that. We would screen every 2 to 3 years up until age, 2 to 3 years up until age 64, 65. And one of the innovations that we've had in just the last couple of years is testing for HPV, the virus that's been associated with cervical cancer, with warts, genital warts, and that can cause cancerous changes. And so if you get tested for the HPV virus and you get your pap smear done at the same time, they do the HPV testing off of the pap smear. If those are all negative and you're over age 30, we can do pap smears every 5 years. So I'm encouraging a lot of that in my women patients now because, if it's negative, it's great. But doing HPV testing routinely at age 21 to 30 doesn't have the evidence that it's going to be as helpful. And probably more important to the younger populations is getting immunized for HPV. And now that's a level A, B recommendation for boys and girls for HPV virus vaccination. So every 2 to 3 years, College of Obstetrics and Gynecology may suggest more frequently than that. And then with HPV testing. And then when to stop is sort of dependent on what the situation is. If you had a hysterectomy and it wasn't because you had cervical cancer or some sort of cancerous condition, once you had your hysterectomy, you don't need to have pap smears anymore. Conventional wisdom used to be you do one pap smear after you've had your hysterectomy, but really we just did that just to reassure ourselves, but it's not necessarily a recommendation. If you make it to age 65 and you've never had an abnormal pap smear and you've had a couple of pap smears at least, in the last 10 years you've had like maybe 3, we don't have to continue pap smear screening. And this is the example of where the lead time is. From the time that you get exposed and start getting the changes of the cervix to the time you get an invasive cancer can be on the order of 7 years. So not that you can do pap smears every 7 years, but that because there's such a long time between change to abnormality to invasive disease, we can play the odds that say that after age 65 we don't need to continue to do that testing. Okay? Now, if you tell me that you have a new sexual partner after age 65, that that changes the equation. Maybe we have that discussion, but that's a separate talk. So, pap smear screening is a level A, and as much as we know we've got good tests out there and we can add the HPV testing, one of the frustrating situations is that not enough people are getting them still. Still only about 2/3 of our women get pap smears based on recommendations. Okay, colorectal cancer, third most leading common cause of cancer in the United States, and depending on which one, can be a high cause of cancer death. We know that you start with a 5% risk at age 50, and then those change obviously if you have a family history or any kind of symptoms. That when we do the colon cancer screening, what we're looking for is bleeding or polyp formation or irritation caused by polyp formation, and that adenomatous polyps are the bad ones to find. And that if you have a familial condition of hereditary polyposis, where you're actually if you looked in their colon, they had like tons of polyps, that they're at highest risk for developing cancer. So we do have a couple of different tests available to us, and March is Colon Cancer Awareness Month. But we have occult blood testing where we can test the stool for bleeding, and there's more sensitive tests now called the immuno occult blood test, so the IFOBT, which you could do on an annual basis, but we have colonoscopy that we can do starting at age 50 and do once a year every 10 years. And we're not really sure when to necessarily stop the testing. But it's 10 years if they don't find anything. It may be 3 to 5 years if they find a polyp and we need to do further surveillance. We also have flexible sigmoidoscopy, which can be done 5 years, and the difference between a flex sig and a colonoscopy is length. So a flex sig just goes from the rectum to about the splenic flexure. The colonoscopy is able to look the entire length of the colon. And then we also have the ability to do barium enemas, an X-ray test that has about comparability to the flex sig and can be done every 5 years. So, you know, take-home message is that we've got a lot of different ways of screening for colon cancer, and deciding which one's the best for you is, again, a personal preference, as well as what's covered by your insurance, as well as what's available to you. Okay? And here at Billings Clinic and here in the Billings area, we've got pretty good tests to screen for these sorts of things. And one of the interesting things coming here, when I practiced in St. Louis, Missouri, is that, you know, we didn't have direct colonoscopy screening. Everybody had to get referred to the GI doctor before they got the test done. But now, you know, we can make that kind of referral to a colonoscopy clinic to get the test done, so it's a little bit easier, less hoops to go through to get the testing done. And, you know, it's a straightforward sort of a test. I'll be 51. I haven't scheduled mine yet, but so at some point maybe I will. But yeah, exactly. You know, there's reasons. You know, again, individualized sort of decision making.
So do you remember, do you recommend that CAT scan?
No, I didn't, because it's not. Yeah, the question was whether or not the CT colonography is a recommended test, and that's, I mean, in places that do the test, it's sort of like a fancier barium enema, and so, but it tends to have more cost, isn't any better than some of the other tests, and so.
And if they find something, they still have to go back.
Mm-hmm. Yeah, and that's why the gold, and like you said, if we find an abnormality on the blood test, the stool test, or any of the other tests, we have to do colonoscopy anyway to directly visualize and see what's going on. And so that's why colonoscopy has sort of become the gold standard, because if you see something, you can actually maybe take care of it right then and there. If I see a polyp, we can take care of the polyp. If we have an area of abnormality, we can biopsy it and find out in a couple of days what's going on there. And so it doesn't lead to additional testing. You can start intervening sooner. But, you know, because these tests are so reasonable, I tend not to push the CT colonography, and I don't know that it's any more advantageous than the air contrast barium enema. Okay. So again, individualized recommendations. We might want to start doing screenings earlier based on family history. And then, you know, if we can get the colonoscopy even once, that may be enough at least to see what's going on and make sure things look clean. And then, you know, do other surveillance testing like occult blood testing, you know, afterwards. So, you know, God love you if you get your colonoscopy and you have a second one done 10 years later and a third one 10 years later after that. But, you know, that we haven't been doing it enough that we have that many people that have done it. Has anybody had 3 10-year colonoscopies? Okay, all right. So you've had them before, and I mean, you know, it's a good test. And as much as we have in our minds like, oh my gosh, this is going to be a horrible sort of experience, it's gotten better, and doesn't take nearly as long, and the prep isn't too bad. Okay. So U.S. Preventive Services Task Force, starting at age 50 up to age 75, a recommendation, so it is covered under them, and you shouldn't be paying a copay. Okay. So these are some of the other things. I think, you know, colon cancer, breast cancer, cervical cancer. We'll talk about prostate cancer in a second here. The other big one out there that I don't have slides set to talk about is lung cancer. And the recommendations for lung cancer screening are based on if you have a lifetime history of smoking more than 300 cigarettes over your lifetime, or what we call 30 pack years. Then you can do a spiral CT of your lung to look for abnormalities. And that is a newer recommendation, but the evidence isn't strong enough that it's, a universal recommendation. But if you are at risk, your best test for screening for lung cancer would be the spiral CT. If you're not a smoker, your risk is really low. We wouldn't routinely recommend that sort of a thing. And a simple chest x-ray is not a good screening test for lung cancer. It's great for looking for pneumonia and any number of other things, but it's not technically a good cancer screening test. Okay? Screening for diabetes, if you get blood work on any regular basis, you'll probably get your glucose looked at. So, checking a fasting blood sugar, checking a random blood sugar is a way we screen for diabetes. We have the hemoglobin A1C test, which tells us how your body has been working with blood sugar over the last 3 months, and higher percentage numbers are more indicative of diabetes. But technically, the A1C is not a test to screen for diabetes. But realistically, people will still use that test to kind of look for diabetes. Bone density screening, again, is based on a tool of what is your 10-year fracture risk, which then we would push for more screening or less screening. But basically, it still stands at age 65, it's covered, and then periodically thereafter, depending on what your risk is. And then to do it before age 65 if you are very high risk based on the FRAX estimation. Prostate cancer, again, there's a lot of it out there, a lot of cancer death, but most men will not die of prostate cancer. And so that's where the screening for prostate cancer has become more of a challenge. And the recommendations from Cancer Society, the Urologic Association, the U.S. Preventive Services Task Force, specialty organizations is all over the board on there. And so U.S. Preventive Services Task Force has an indeterminate recommendation. So Medicare will cover a screening PSA at age 65. It will cover a screening PSA for other reasons if it's a screening test, but routine annual PSA tests would not be covered. And so that's one of the interesting sort of challenges is like how often do we need to get the testing done? And then the ways that we can screen for prostate cancer are the blood test, the PSA, or by directly feeling the prostate for any nodularity. Okay. And so really the best recommendation from the Preventive Services Task Force is have that conversation with your provider about what are the risks, what are the benefits, because we, again, like mammograms in young women who end up getting more testing done, if you have an abnormal PSA, it leads to additional testing down the line that may or may not be in your best interests to find something that may or may not change the course of your life. Sir?
If you had were treated for kidney cancer, would that be a reason to continue with the PSA?
Yeah, so the question is, if you had kidney cancer, is that a reason to get your prostate cancer screen? And they're separate cancers, so it wouldn't necessarily be reason to get one over the other. Interestingly enough, though, smoking across the board is associated with increased cancer risk for all of the different cancers out there. And what I mean is that if you took the epidemiologic studies and looked at, esophageal cancer, lung cancer, colon cancer, prostate cancer, breast cancer, and you looked at did they smoke, did they not smoke, invariably more smokers than non-smokers have those cancers. So then the question is, what about secondhand smoke, and does that increase your risk? And that one's a harder one to study. I would think yes, but also it's going to be dependent on how much secondhand smoke are you getting exposed to and what other risk factors that you have. So no, I mean, it's easy to take the epidemiologic study and say, if you smoke, didn't smoke, if you're exposed to smoke, you weren't exposed to smoke, and what your risk is. But they won't take it the other way and say that if you have this, you will get this or you won't get this. So that's just one way of looking at the issue. Okay. One of the other recommendations at age 65 is aortic aneurysm screening, looking for a widening of the aorta in the belly that could be at risk for breaking and leading to death. And again, this one is a recommendation based on your sex and smoking history. So it's really only recommended for men 65 to 75 who have smoked. But interestingly, it has smoked at all. So, sir, when you come to my office tomorrow, it's going to be, if you've ever had a cigarette and you're between 60 and 75, the recommendation is to get a screening for this. But if you're a woman or if you're a man who never smoked, the recommendation wouldn't apply. Skin cancer, as much as we all are aware of it, wear your sunscreen because look for lesions. But routine screening, going into the doctor's office to have your skin looked at, probably doesn't lead to anything. But if you already had a lesion, seeing your dermatologist who, is good at looking for these sorts of things, that changes the story. But in general, we won't intervene earlier with that. Okay, the last thing is vaccinations. I can't stress enough the importance of trying to disease risk burden for diseases. Annual flu shots, hopefully everybody got one this year. If you had a pneumonia shot at least once after age 65, recommendations are once before age 65 if you were a smoker or at risk for things, and at least one after age 65 for everybody, and at least 5 years between those two tests. We now are looking at the Prevnar 13, which is the pneumonia shot we give to kids, that if you are immunocompromised or have a history of cancer or a number of other conditions, in addition to the 23, the adult pneumonia shot, you should also get the kid version because they cover different pneumonia strains. Tetanus shot every 10 years. If you've had if you haven't had the pertussis, the whooping cough booster shot, that's a Tdap as opposed to a TD test immunization. And recommendations are at least one Tdap after age 30. And then once you've had one of those, then you're good to go, and you can just do the regular tetanus shots. So that's always a tricky one because nobody ever remembers, well, did I get the tetanus shot or did I get a Tdap? And invariably, we've always been giving TDs. So you'll get at least one, now with electronic systems where we can record what you got, at least one Tdap after age 30. And then the shingle shot, actually varicella is different, but the shingle shot is recommended at age 65. It doesn't have the level A or B evidence, so it's not necessarily paid for by Medicare and the insurance companies, and I'll need to double check that bit. But check with your insurer because the out-of-pocket costs can be a little pricey for the shingles shot. And the question is, if you've had shingles, do you still need the shingles shot? And the current recommendation is that yes, it's still recommended to get it because then if you got it again, it may not be as bad that next time out. That's the thinking behind it. Okay? So we covered a lot of areas here. And these can be summarized in annual visits for men and women based on your age. And again, these are going to then be recommendations for screening tests, for vaccinations, for health counseling, and then higher risk sorts of things if you have something else going on. But for our audience today, let's just go ahead and look at women 50 to 64. Again, based on the best evidence, getting your mammogram screening the U.S. Preventive Services Task Force changed it to every 2 years. A cholesterol screening at least every 5 years. Colon cancer screening every 10 years. Unless you're doing some of the other tests, then it might be more frequently than that. And then aspirin for stroke prevention. Bone mineral density if you are at higher risk. Screening for diabetes, HIV, breast cancer if you have other risks. Immunizations and then counseling. For women 65 and older, again, it's not so much which tests do we do, but when do we stop doing the tests. Same thing for men. And so there, take-home message is, go to your doctor. Develop a relationship with a primary care provider so that you can have these conversations about what I need to have done, what I shouldn't have done, what I definitely don't need to have done, and then you tell us what I won't be doing. Because, again, it can't be hammered home enough. There's a lot of good things out there. There's a lot of good tests out there. In general, cancer screenings can make a big difference in our lives. But for the individual person, kind of risk stratifying and having the conversation of what I do or don't want to get done is important. And so if you have that relationship with a primary care provider, you are more likely to get those questions asked and answered. And if there's opportunities to screen and find things, we're more likely to have it done, find it at an earlier time, and cause better outcomes over the lifetime.